All right. Well, welcome everyone to the continuation of our afternoon
Recording
session.
in progress.
I apologize. We have some more technical challenges today, so we're building our resilience and our cognitive reserve in the middle of the meeting. So thank you all again for joining us. I think we all agreed that we had a really productive morning session. I mean, being able to see some of the new innovations in clinical care, how that interacts with the public health interface, new therapeutics, new coverage models. So a really exciting morning, and just being able to see a lot of the things that have been a part of NAPA for all these years coming to fruition, and new grant opportunities, programs, and other new drug treatments. So a very exciting morning. And so now we're going to continue with continued recommendations. Again, we know our work's not completed yet, and so there's a lot of work to be done still. And so we will be hearing from each of our different subcommittees. And just to remind those that are not familiar with the process, each of the subcommittees for NAPA meet on a regular basis, at least monthly, and discuss different issues within clinical care, long-term support services, risk reduction, and research that are of high importance. And so trying to highlight areas to bring to attention of our partners, both the federal, non-federal, hopefully to states and other communities as well, to share in working towards these goals. So we will start with our research recommendations and then move into how we approach disease progression. So with risk reduction, and then to clinical care. And then last, we'll review long-term support services. And I do want to take a moment to really thank our subcommittee chairs for leading these groups. So Dr. Joanne Pike leading the risk reduction group, Dr. Maria Moore, I was about to call you my colleague's name, Dr. Maria Ortega. I have a lot of Marias in my life who I think are wonderful. So Dr. Maria Ortega for leading our clinical care subcommittee group, Dr. Randy Bateman for leading our research subcommittee, and then Carrie Mulkey for leading our long-term support services. So their leadership of each of these committees, bringing together these ideas, organizing them, and then presenting them today. So thank you all so much for all your hard work. A lot of behind the scenes work goes into these recommendations. So with that, I'll turn it over to Dr. Bateman to talk about research updates.
Okay, so the research subcommittee has 6 recommendations this year, and I'll step through each one of these as we advance to the next slides. There we go, and I'll leave you here just for a second. And the research subcommittee this year had quite a bit to deliberate on because of all the very rapid research that's coming to the forefront, some of which we discussed earlier that are being announced at scientific and medical meetings, but especially how these research findings impact in really what is amazing time from the time of discovery until things happen in the clinic now is being measured in a very short few years and even approaching months now. So the committee has been very active. I want to thank each one of the committee members for earnest engagement throughout this year. And I just like to highlight one person who has assisted me greatly as the chair of this committee is Melody Lee, for really helping organize and run these meetings to bring forward this information. It doesn't feel amplified. So is the mic not working or? Okay, I will. Oh, we were missing someone. Please go back. So Helen should be listed there as well. Helen Bundy Metzger. Sorry about that. Thank you. And I don't want you to pay so much attention to the right-hand side of this slide. We wanted to really highlight all the exciting and different things. But on the left-hand side of the slide, you see we purposely made this our #1 recommendation because we believe this action will have immediate and sustained impact for patients' health going forward. And so we are recommending an increase to the federal research funds to meet NAPA's stated aims. And we heard earlier today from Dr. Hodis and the other NIH folks about how additional funds are needed to meet the opportunities that are at hand. We fully endorse that because the scientific and the medical community has had very recent breakthroughs that if we leverage and we keep pushing forward, we can take these learnings, these advancements, and learn how to better apply them, how to take advantage of them, and how to translate these to other disease areas, not just Alzheimer's disease, but other disease areas. And so you'll see on the right-hand side is a list of our various basic translational implementation recommendations of things that we believe that if these are implemented, will translate into future benefit for people. And so right now we understand the call here is a top priority remains the urgent need for Congress to increase the annual federal research and implementation science funding. And we specifically call out the NAPA process of the professional judgment budgets by the NIH and other agencies. Okay, next slide. Our second recommendation. Okay, well, I'll just start. Our second recommendation really was a reaction to the wonderful time that we're in now. We now have new treatments, new drugs that can change the course of Alzheimer's disease. And so based on that, there are a lot of questions that we don't have answered yet. Those questions are listed here to address critical scientific and clinical questions in the implementation of the first generation of disease-modifying treatments. Research is needed to determine, and then we list the questions that we think are most urgently need to be addressed. And this really has to do with the unknowns that we have. What we know is that these drugs can slow down the progress of the disease. We know that they can largely fully remove amyloid plaques as we measure by PET scan. But the specifics of, for example, how to identify people who would best benefit from these treatments, which persons who have this but don't fit the current criteria that are included in this clinical trials, which of those people would benefit? What kinds of infrastructure will be needed to deliver these therapies? We need to understand better the side effects, and there's a side effect associated with these medications called amyloid-related imaging abnormalities, where we really need to understand what is the impact, what is the risk, how can we mitigate this? Are there certain people who are at higher or lower risk of these potential side effects? We recommend studies and diagnostic testing options to identify people who could benefit, and whether treatment of cognitively normal persons identified as high risk based on these biomarkers could delay cognitive decline. There are clinical studies underway right now trying to answer these questions, and so there's many ways to do that, though, and so we think there's additional opportunities here. And then finally, how do we manage people over longer periods of time? Once we initiate treatment, how long do we continue treatment for? How much benefit is seen? What about comorbidities and other medications? These are all questions that we think have a high priority for being addressed from the research front. Next slide to recommendation number 3. We highlighted this challenge of implementing research in active dementia care models to compare effectiveness. And this morning we heard from CMS about an exciting new program, a model that's being rolled out to address this. So this is fantastic. The day we announce our recommendation, actually before we announce the recommendation, it's already being acted on by CMS. So brilliant, brilliant. And this is critically important because patients, people with the disease, are not in a vacuum. And it's not just about a diagnostic test or a treatment. It's about taking care of the whole person. And what ways do we have? What ways can we implement to really do that? And these new approaches, these new strategies to try to determine that offer the promise to potentially be able to do this in a much more thoughtful, a much more supportive way that will lead to better health care for not just the patient, but their families and caregivers. And in the clinic, we have a saying that when someone comes in with Alzheimer's disease, there's always at least 2 patients, the person with the disease and the caregiver. And you have to take care of everyone who's impacted by the disease, and this promises to be a way to do it. Let's go on to the next recommendation, recommendation number 4. This recommendation has been a frequent recommendation from our committee and others, and it's been highlighted in research that we're not doing good enough in this. And so we've reiterated it here and tried to add more granularity about the ways we think this can be better addressed. So the recommendation is to address health equity and representation in research, and representation and diversity in the clinical trials needs to be increased. Our clinical trials don't sufficiently represent the general population. And there are ways to do it. They are not easy. There are challenges and inefficiencies, but it is possible, and we are at a time where we think it can be done and needs to be done now. And so we have listed these approaches here, A, B, C, and D, trying to highlight the importance of inclusion in public and private clinical trials to fund the research on recruitment science. What are the scientific ways that we can determine how to enroll a representative population? There's another part to this, which is the stigma related to the disease, and health-seeking behaviors are going to have a huge impact on the equity of delivery of care to patients and communities. And so we need to understand that and enable our systems, design our systems so that they deliver on it, because the promise is better health for everyone. And there are ways to do that, and so we think now is the time that these really need to be enacted. Recommendation number 5. Next slide. So this is a reminder, and we see several distinct opportunities to help the mission of NAPA move forward. As many of us, some of you all have been on the committees for 10 years, I hear, or longer, and I've served for now 2 years. What is clear is that NAPA and its goals need to be supported. They cannot be unfunded mandates. They have to have proper resources. And so what we list here are 2 recommendations, sub-recommendations here, that the NAPA organizers, including ASPE, should have increased resources, including financial and personnel support and authority to accomplish the following. And the following is a list of the NAPA aims and the general goals to track the progress and milestones for the NAPA recommendations, and to assist NAPA Council and its chair in determining the level of appropriate resources, but to really make sure that those financial resources and the people resources are there to meet the stated aims. And then the second one is, in order to meet the scientific recommendation goals, this is more specific for our particular subcommittee, that there should be some independent funding that supports those activities. And much of the activities that we've heard about today have made extraordinary progress. It's really quite amazing when you look back 10 years when NAPA started about the progress that's been made. But now that we're in this era where so much more can be done, it's appropriate to increase the resources for NAPA to continue to meet its stated goals. And then finally, on recommendation number 6, we have a scientific recommendation to use scientific approaches and evidence-based evaluations of the factors for decision-making. So this includes models, numerical calculations of the impacts of decisions across the agencies, across the deliberations of NAPA and in research. This is a given in scientific research, but these same approaches can be applied in other areas so we can understand the quantitative impact of our decisions and what impact is there on health and how many people will be affected and in what ways. And so we detail some of the opportunities here that range from determining the safety, utilization, and outcomes, successful models for increasing involvement of people in research, including trials, and the impact of these new generation of therapies on patients. And so with that, that concludes the research committee's recommendations. Thank you.
Any questions on the research recommendations? right, if not, then we'll go ahead and move on to Dr. Pike. We'll review the risk reduction recommendations.
Thank you. And like Randy, I want to start with a thank you to the committee. If I think we need to go to the next slide. So this is our subcommittee, both non-federal and federal members. Big thank you to all the work that you have done over the last year to get us to this place with our recommendations. But also I'd like to acknowledge, similar to Randy, the support that I get on the back end behind the scenes to make sure that the recommendations are tracked and created in a way that are feasible. And that's Matthew Baumgart, our Vice President of Health Policy at the Alzheimer's Association, provides a significant amount of support to me. So a big thank you to Matthew. So let's dive into some kind of preliminary thoughts around our recommendations. For the last year, the Risk Reduction Subcommittee has not only thought about in the last few months our recommendations and what we were going to do with our recommendations, but also went through a series of a couple of presentations around topical areas that were of interest to committee members to make sure that they were informed on. And I want to talk about some of those themes that kind of arose and that we consistently continue to revisit. One of the first ones was equity, and you'll notice that there are new recommendations on policy and systems change throughout the set of 6 recommendations around health equity, and in particular, the barriers associated with accessing care and conditions like the social determinants of health and what need to change around those. We also had a theme throughout the year around prioritization and evaluation, and to really look at prioritizing efforts by focusing on 6 potential factors within the list of risk factors, and those aged 40 and older to make sure that we're impacting that population in particular. And then the third theme overall that I would put into kind of our discussions was around inclusion. And there are a set of recommendations associated with the intellectual and disabilities, or intellectually disabled group that we have included within here, and also around tracking prevalence with that group and their risk factors for clinical identification. So those are 3 areas that we consistently visited over the course of the year, and you will see flow throughout the recommendations as I go through those. So let's start with recommendation 1 on the next slide. This recommendation is really focused on prioritization and tracking. And the way it reads is to identify priorities for and track progress toward addressing decline in dementia risk factors across the life spectrum. And the main goal within this is to really think about what needs to be prioritized. How can we focus on 6 risk factors that were identified as having the most opportunity, and really focus in on how do we evaluate, where do we track them, and what federal actions can we be taking in order to meet those. I want to highlight those 6 because those do come back around in subsequent recommendations. Those are midlife hypertension, midlife obesity, physical activity, smoking, depression, and hearing loss. And then recommendation 2 is really about accelerating the network capacity. This is to accelerate public health and aging network action on addressing risk factors with the strongest evidence of beneficial impact on dementia prevalence, particularly for communities or target groups at risk. Our focus here was in not just federal government. What can we sustain and strengthen through funding levels and expanding efforts, but also around partnership and strategy specific to the underserved community and around social determinants of health. Earlier today, the idea of how can we integrate with the Million Hearts campaign as an example was brought up. And I want to highlight in here that this is also an area where we really thought about how can we align with other federal campaigns with strategies that are focused in on risk factors, and that's a specific recommendation within this as well. Moving on to recommendation 3. This recommendation can be summed up with the idea of clinical care and how do we integrate reducing risk factors within the clinical care area. This is multi-sector, multi-domain recommendations on assessing risk factors across payers, systems, and providers, certainly inclusive of benefit design and educating providers. In addition, it really looks at how can we use existing mechanisms to pilot, whether that's through CMMI or through addressing coverage gaps with federal programs for interventions that do have evidence like hearing aids. On the next recommendation, you will see we begin to think about research and what do still need to be researched around risk factors. So this is to initiate and fund research to strengthen the strategies for addressing the risk factors of dementia. So this is not just about understanding what does lead to dementia, but also the interventions, the strategies to address those. This includes fundamental principles around diversity, equity, and inclusion. It also looks at federal government focus on multiple areas, inclusive of understanding causal pathways, translation of research in the community. And then also, it's important to understand what the COVID-19 pandemic still continues to have impact for risk reduction overall. On the next slide, we get into recommendation 5, which focuses on the non-federal sector. The appropriate non-federal government entities and private sector organizations should work to improve brain health, specifically around state and tribal agencies, foundations and charities, medical associations and health systems, provider organizations, and with a segmented focus on community organizations and areas of need. On our last recommendation, recommendation 6, this is a new recommendation. Thank you, Rhonda Williams, for making this recommendation that we grappled with there towards the end of our process. But this is really looking at what can we do on a policy level. So it's mainly focused on policy initiatives, establishing a set of dementia risk reduction policies at the federal, state, and local level that will address risk factors, including social determinants of health for cognitive decline. These two recommendations really look at federal, state, and local, and how can we take those 6 priority areas and make recommendations that each of those localities can pick from a policy intervention set of recommendations. And then also, how do public health, nonprofits, and medical associations collaborate on identified policy initiatives? And with that, those are the 6 recommendations from the Risk Reduction Subcommittee, and I'm happy to answer any questions.
Any questions for Joanne? Randy? Before you can get it up.
Well, a question maybe just for the group. So number 6 seems to be really important in terms of affecting the changes that are needed to help lower down the upcoming growth in the incidence of Alzheimer's disease and other dementias. And so one thing we've talked about at prior meetings was the challenges in doing that. That for a long time people have been trying to control blood pressure for a variety of reasons, and tobacco exposure, and most of these, although some of these are new. And so one can argue these would be good regardless of their downstream effects, but certainly preventing dementia is a good reason. Are there opportunities, or are there avenues to where these kinds of recommendations could be further taken up or championed in some kind of way to have a bigger impact than what people are already trying to do?
Yeah, I think one of the things that I would add is if you look at that list, those are all proven policy interventions in other chronic disease spaces. So there is, this is making a recommendation that really looking at those existing policy interventions, because those really cross into a lot of core areas. There might be one on there that does not have an existing recommendation on for intervention. But the fact is those are things that can be readily used and available. It's a matter of making it known that it does impact dementia as well, or brain health, and really looking at how can we mobilize on that front. But to the point earlier today, there are coalitions and collaborations that work on these core issues now. And how can we leverage that information, and also implement it within the clinical space as well?
Have these been tied to dementia? You know, Alzheimer's disease, and your association has taught us all this. Alzheimer's disease is the most feared disease in people over the age of 65. And so, you know, when people hear that, when people think about it, you know, controlling blood pressure for this or that might be one thing, but if you actually said your risk of getting Alzheimer's or dementia goes down, that could potentially be a major motivating force. Mm-hmm. And I know that in my own clinic population, it's not so common. Things like exercise, blood pressure control, it doesn't come to the top of their minds that, because when we talk with people, we tell them, you know, well, for the caregiver, the spouse, you don't have dementia, but you don't want to get it, right? So you can exercise with your husband or wife. You can do these things and protect yourself as well as help your loved one. And so I'm just wondering, you've said there are these existing things. I just wonder if this isn't an opportunity to try to somehow leverage what is known about risk reduction in Alzheimer's and these other disease areas to have a bigger impact. Are there ways to improve it? Where will these changes be enacted, do you think? Will this happen at a lot of different levels?
Yeah, absolutely. And I think if you know, as we went through those recommendations, you kind of see the build in those levels, right? There's federal, there's non-federal, there's clinical, and how do you integrate these within the clinical landscape? And then this is really the policy side of that landscape, the policy implementation. And that's why I think the group, and I don't want to speak for the full group, really looked at those 6. How can we take the list from what we had before and really begin to think about what are the 6 that have the greatest potential impact? And then how do we weave them into that multi-level, multi-domain intervention capacity? This one specifically focuses on policy, but if you look at the other ones, you begin to see how it really lines up with multiple other areas as well. But agree with you. We have the knowledge. It's a matter of then leveraging that communication within those other channels as well. Yes, Sherry or Arlene.
So thank you again for these high impact recommendations. I think very, very supportive. I think if we look at the layers here, it will take us forward, mm-hmm. Because there's not a week that goes by that, you know, we're not seeing people with blood pressure that could have been better controlled in our clinics, but beautifully recorded in the chart. So, you know, that's making 2 points. One is right. Within the healthcare system, it has to be like everybody's job to support the actions that could be taken. But the other is, you know, how do we also make this actionable and important for communities and beyond the walls of healthcare? Right? Because I think sometimes the message is better received when you're doing it together.
Yeah.
And it's not the doctor. I mean, not to say that the doctor isn't extremely influential, Randy, but I think it's, you know, if we approach this from different angles, I think there are different messages for different audiences, but the signal is important and it's right on target.
Yeah, thank you. And I think it's a nice blend with what Lisa and I were talking about this morning from the Healthy Brain Initiative roadmap, and how that is also a public outreach opportunity that is woven into these recommendations throughout. But it's also important to recognize that it does have to come from multiple people. And the one with the most influence is more than likely not the doctor. But with that clinical landscape in mind, and how do you use existing resources to change behavior in the clinic Arlene, I imagine you might have some thoughts and might be where you are leaning to from a quality improvement perspective on how do you take that data point that is being utilized and translate that to action.
So yes, so no, this is wonderful, and it's so exciting to see this in the NAPA, recommendations. And like my thoughts are coming, I had seen all these individually, but kind of seeing them all together and how they fit together for a pattern. And for this one, the first thought I had was, how can we link this to some of the department priorities? So the ones I'm thinking about are strengthening primary care, because without investing in primary care, they're not going to have the capacity to do this. They're overloaded and under-resourced. Integrating behavioral health in primary care, managing depression, recognizing cognitive impairment, and then addressing the social determinants of health. And all of that takes linkages between, clinical care, primary care, public health, and social services. And so is there a way to kind of call out somewhere, maybe at the end, synergies across all of these recommendations, and then maybe, link it to like department and, administration priorities? I'm just brainstorming, but that's just what struck me looking at this.
Yeah, I think it's a great idea, especially when you think about it from that multi-level intervention. What are we asking each of those types of levels to do? Yeah. Thank you. Any other questions? Yes, Ken.
Comment that it's the CDC Healthy Brain Framework covers some of the components. That framework, the purpose is to reduce risk. So there's a lot of common things, and it's already being implemented. Having the framework and identifying chronic disease that may contribute to dementia. That's why you were talking to Lisa. I understand.
Yeah.
So
yeah.
I understand that we're getting closer. Just got to implement it further.
Yeah. And if you read through the details on each of those recommendations, I didn't want to torture you by reading every single one, just like Randy didn't. But it's, we call out specifically opportunities within the Healthy Brain Initiative and also the BOLD funding areas. But also there's other funding areas through, for instance, the Aging Network as well, that have nice synergies. Okay, thank you, everyone.
Thank you. Excuse me, I'm having coffee right here. Thank you so much for that good discussion with for risk reduction. And now we're going to move on to the clinical care recommendations. So Dr. Ortega.
Good afternoon, everyone. And so on behalf of the Clinical Care Subcommittee, I am going to present our clinical care recommendations. Can you hear me okay, or should I? Okay, a little more closer. There you go. Okay, good afternoon then. And so I would like to recognize also, the subcommittee members. And because I am a nurse and that's how it guides my practice. And I was actually going to end with this, but because we have this slide first, I would like to say that each one of you in the Clinical Care Committee embodies what we call caring in the terms of the 6 C's of caring, okay? And so these are commitment, competence, compassion, conscience, confidence, and comportment. So I felt, very, very comfortable, immersed within every one of you, even though through a nursing lens, we work as an interprofessional team. And so also, I think I'm going to speak on behalf of everyone, Dr. Pike, this time, and that across all of our recommendations set forth by the various subcommittees, it is fundamentally crucial that all educational materials, protocols, and plans of care be culturally tailored in order to deliver comprehensive, effective, and person-centered dementia care. And these materials and approaches must consider the variations in language, cultural norms, health beliefs, and social contexts that exist within different communities. And this approach, we believe, that promotes greater understanding, engagement, inclusivity, and reduces social stigma. And we've discussed all these concepts prior. And I also want to add a thought on that, that even though there are variations within the different cultures, there is also that uniqueness of the person that we need to take into consideration, not only the culture, but that personal experience. And so moving now with recommendation number 1. And the theme that we have for this recommendation is increase public education and awareness for AD, ADRD management. And you see, the title there, and increase resources to educate the public. But I want to say that public includes patients, family caregivers, healthcare administrators, clinicians, and community members. And so in this recommendation, raising awareness about the disease and enhancing understanding within communities is a crucial first step in getting individuals to seek out clinical care for cognitive concerns. Awareness strategies should focus on reducing stigma within diverse communities and how to access resources and clinical care and how to engage in supportive decision-making. And again, as a clinician, I think that I see every setting as a clinical setting. So here is where the community is a clinical setting, right? Is where the patient is. So I think that all of us, are expanding our view and at the same time integrating, our different recommendations. And so we are going to move on. Recommendation number 2. And the theme for this recommendation is promotion of healthy aging, early detection, diagnosis, and management of AD, ADRD. And we've heard that through research and also through risk reduction. And the focus on translating evidence-based recommendations into clinical practice for AD, ADRD care involving a variety of stakeholders. Implementing these recommendations requires enhanced person-centered communication, family caregiver inclusion, education, care coordination, and a broad workforce training. Also crucial are the effective dissemination of guidelines, continuous quality improvement strategies, ensuring universal care access, and promoting health equity. And so you see that we have actually 2 slides of recommendation 2 details. And, some of the highlights are, that hospital and healthcare provider practices serving people living with AD, ADRD, or older adults at risk for should put in place procedures. And for example, to implement dementia education in annual training for all staff and supporting a dementia-friendly environment. To identify cognitive decline and integrate management of cognitive impairment into care plans. To enhance primary care capacity to diagnose and manage ADRD alongside other conditions. And then not only in primary care, in my practice, I have a lot of referring physicians and practitioners who are, from endocrinology, cardiologists. So again, this also expands through all the specialties, and to streamline care pathways for accurate, timely AD, ADRD diagnosis with optimal resource use. And also promote patient caregiver engagement with self-management strategies and personalized care plans and the use of decision aids. So now I'm going to move on to recommendation number 3. And the theme is addressing the clinical workforce crisis by improving capabilities for AD, ADRD care. And we're speaking here about the workforce for all the clinical care, not only gerontology and geriatrics. And I was referring to my practice, but when I see patients and I said, okay, I think gerontology is becoming younger and younger. Right. So not only we see the patients younger and younger, but we see the need to, again, identify the risk and to also, address the risk factors, right? And so where do we do that? And so I think that we're missing a lot of opportunities in pediatrics, right? Everywhere, because I think that we have to begin young, right? As early as possible, I would say, in order to make an impact and change, let's say, the course of some of these progressive disorders before, it really gets more difficult. And so the shortage of healthcare professionals specializing in dementia and geriatrics and gerontology as well, particularly in the context of this dementia care, creates a pressing need for an expanded and more dementia-capable workforce. And the identified dementia neurology deserts in 20 U.S. states by the Alzheimer's Association emphasize the geographic disparities in health and clinical social care access and the urgent need for targeted efforts to address these gaps. And I think before we also heard about two words, diverse and skilled. So this workforce should be all that. And so, it's our responsibility, right, to engage in teaching and training. For recommendation number 4, the theme is integration and coordination of care with emphasis on person-centered care in AD-ADRD. And so by actively engaging individuals with AD-ADRD and their care partners, healthcare professionals can gather valuable insights into patients' experiences, challenges, and strengths, leading to more effective and personalized care, improved outcomes, and enhanced quality of life. Promoting coordination with home and community-based services enhances overall care experience, supports patients in preferred living environments, and ensures comprehensive continuous care across settings. And another thought on this is that I think we just heard that the patient is not only the person, right, with the cognitive difficulties or concerns, but we ought to look at the caregiver and the needs of that caregiver and the mental health care needs of both the person with the cognitive difficulties or dementia or impairment, and also that family caregiver needs. And recommendation number 5, the theme is implementation of evidence-based non-pharmacological interventions for AD-ADRD. Behavioral and psychological symptoms of dementia, or abbreviating it as BPSD, may appear in up to 90% of persons living with dementia. Implementing evidence-based non-pharmacological interventions delivered in a person-centered manner in a supportive environment is essential for comprehensive clinical care. And so we have some essential elements here that healthcare systems, clinicians, and community-based staff should encourage the following 3 key considerations be addressed. One is the environment, the care efficacy, and patient-centeredness. And also, federal agencies and other organizations should fund research, provide training, and create policies. And I think that we've heard a lot of what is already being planned for all these. For recommendation number 6, the theme is implementing Alzheimer's disease modifying treatments, DMTs. And the clinical care subcommittee concluded that a comprehensive dialogue involving diverse experts is crucial to discuss both the opportunities and challenges associated with implementation of FDA-approved Alzheimer's disease modifying treatments and other potentially beneficial strategies. Key topics would include raising awareness of these therapies, addressing the variance in state drug formulary prescribing criteria, defining the hiring and training requirements for DMT experts and patient navigators, identifying how health systems will effectively administer, monitor, and integrate these DMTs with other interventions, and addressing the unique access needs of urban, suburban, rural communities, and underserved populations, including persons with neuroatypical conditions. Recommendation number 7, the theme is care models for AD, ADRD. The approach in this recommendation acknowledges the importance of understanding and addressing real-world practice challenges in implementing these models. That federal agencies, states, and non-governmental payers for healthcare services should enhance the utilization of value-based care for persons living with AD, ADRD, including linking payments to performance on cost, quality, and resource use. Such alignment would support comprehensive person-centered care, leading to improved health outcomes and quality of life for persons living with AD, ADRD, and their family caregivers. And our last recommendation, number 8, the theme is, which aligns with all the other subcommittees, health equity and access to care for adults living with AD, ADRD, but in this case, for younger onset AD, ADRD. Younger adults living with dementia can face eligibility restrictions for certain dementia-specific services due to age-related statutory barriers. First, the Older Americans Act typically requires recipients to be age 60 or older to receive covered services. And secondly, Medicare has a 2-year waiting period for younger individuals living with ADRD, who qualify for Social Security disability insurance. And to address these barriers and assure health equity, legislative actions and a thorough understanding of their impact on beneficiaries with dementia and the healthcare system are required. And so we are recommending that the Older Americans Act requires recipients to be age 60 or older to receive cover services. And so we are suggesting that Congress amend the Older Americans Act to extend services to persons under the age 60 diagnosed with AD, ADRD, and the 2-year waiting period for younger individuals living with AD, ADRD who qualify for SSDI, or the Social Security Disability Insurance, to have access to Medicare poses a barrier, and therefore we are recommending that Congress consider eliminating this waiting period to enhance access to crucial healthcare services. And these are the 8 recommendations from our clinical care subcommittee. Any questions, comments?
Thank you, Dr. Ortega. Questions, comments? Dr. Bateman.
Sorry.
Yeah, go ahead.
Just a clarifying question. So, in our research at the university, in a study called Diane, we see people with mutations. They have very early onset Alzheimer's disease in their 30s, 40s, and 50s. And so this last recommendation rings true to their situation, that if they don't have medical insurance already and they begin to have the symptoms of Alzheimer's disease at that age, they are not covered under Medicare just due to their age. Even though we know 100% that they have Alzheimer's disease, these mutations are 100% deterministic. Some of them can't really get support due to those rules. And so that's a very narrow part of the population. Of course, it's very rare. But I wonder, with this recommendation, is that the goal? Are you trying to cover a gap in coverage of these individuals that otherwise wouldn't be covered by their own insurance through their employers or other systems?
Yes.
More of a clarifying question. That was the goal.
Did you have? Oh, I'm sorry. I thought you were going to say something. Go ahead.
Because I've been through this scenario personally with my sister. And so she was employed at the time of her diagnosis. Now, what you also have to consider is there will be a gap for those people that may not have been employed. To qualify for SSDI, you have to have been unemployed for a year due to your illness or diagnosis. Then you qualify for benefits at that date. Then from that moment, you've got 24 months before you have coverage. So there is a large gap. And so and in many people's cases, if they've left their employment, they don't have coverage, unless they pull their COBRA rights. But then under COBRA, your coverage is going to be more expensive and it may not be as comprehensive as what you had while you were employed.
Thank you for that,
Yeah.
Helen. And also, in the adult daycare programs, persons don't qualify. And so again, their caregivers or the family, the loved ones are working, but the person, doesn't have, access to benefits or anything. So it's really impacting every aspect of their lives. So thank you for bringing that up. Yes, Dr. Janicki.
Maria, thank you very much for that presentation. It's quite comprehensive. It was fun working with you on this particular plan. I wanted to point out one thing, though. In the first one up there about the Older Americans Act, in 2020, Congress did approve a early onset provision to the Older Americans Act. The problem is, and when we found out about it, we did contact Nashua, which is now called Advancing States, and talked to them about it, and they didn't take it seriously. They said, we already kind of do that, and they weren't going to implement any new information or provisions. I'm wondering if anybody else has had that experience. One, two, whether you might want to amend that, since we already have this enacted, to have it more, I don't know if enforced is the word to use, but to make sure that that provision is explained in more detail somehow through the aging network, so they recognize that it's there and it's acted upon, and families are made aware of it.
That's a great point. Definitely. And I am not familiar with the steps, in order to enforce these, right?
Yeah.
But definitely very, very essential what you're saying. Yes. And we should definitely, highlight it. So thank you for that.
Yeah, it was in the Supporting Older Americans Act of 2020.
Yes.
So a little clarification here.
Okay.
The Older Americans Act did not infuse or did not take the younger onset. The Older American Act was not amended to infuse the younger onset Alzheimer's Act into it, but rather they changed the definition of caregivers to make it possible for caregivers of any age to be able to benefit from the LTSS that are available through the aging network, and that's what's been conveyed throughout. Well, that's very nice that whoever the Alzheimer's Association said that in 2020, but that was a not clear communication on what exactly happened.
Thank you for that clarification, Erin.
Thank you so much, Dr. Ortega, and to the Clinical Care Subcommittee for this wonderful work. One thing I just did want to flag on the SSDI Medicare waiting period. I think it is wonderful for the subcommittee to recognize and point out the critical importance of people having access to health insurance and continuing coverage as they are kind of transitioning, once they've been identified as having a work-limiting disability. One piece of good news we can share is that, because of the implementation of the Affordable Care Act and the wider range of insurance coverage options that we now have available, post 2010 and 2014 in particular, including expanded Medicaid eligibility in a number of states, the health insurance marketplaces, The good news is that there are now additional options for people who are in that Medicare waiting period. I think it is a key and critical research question, actually to kind of be able to understand what those impacts are and what the remaining gaps are for people who have a disability but are still facing barriers to obtaining healthcare coverage in that waiting period. That's a really important kind of question, I think, for us to tackle and understand so that we can make sure that we're more optimally targeting access to those insurance programs to people who find themselves in that situation. But just, did want to note that fortunately we have more options now than we did a decade or so ago.
Thank you. A lot of great news today.
Other questions or comments? Great. If not, thank you, Dr. Ortega.
Thank you.
And subcommittee. We'll move on to Carrie Mulkey will present the long-term support services recommendations.
Fantastic. Let me first start with a sound check. Can you hear me okay?
Yes.
That sounds great. Wow, what a day. I'm so mad that I'm not there with you because I've had to do my own celebration here with my camera off in my little home office here. But really just such an energizing day with the news shared this morning, and also just really reflecting on these recommendations and how powerful and impactful they are, and also how much they really sync and align across all of these spaces. So some of the recommendations that were put together from the LTSS subcommittee that I'll be sharing with you today really, as I mentioned, just are very cross-cutting, as well as I have listened to some of the other recommendations from the presenters today. So I too want to make sure to recognize and acknowledge the members of our subcommittee who I have felt just incredibly honored to have had the opportunity to spend time with all of you and have had some great conversations about the gaps that we really see still in the LTSS world, the LTSS system. And I'm a firm believer, as I know many of you are, that our ability to be happy and healthy is really directly influenced by our living conditions. And it is the LTSS system that really defines where people get to live and work and engage in community. And so it is really important that we spend time focusing on this particular system and making the various improvements that we would like to see for people with dementia to live in the community as long as possible. And if they do live in institutional settings like nursing homes, that they receive quality services. So we too have 6 priority areas, which I was smiling over here too to learn that 2 of the other subgroups also had 6 priority areas. And these all intertwine. So I just will quickly summarize all 6 of those areas, and then we'll dive into a little bit more detail within each of them. So the first priority area really looks at access. So access to long-term services and supports, programs and providers. And then the second is that when people are accessing various services through programs and providers, that people are receiving quality services. So really looking at person-centered and strength-based care. The third priority area is looking at the workforce, and that has come up in other areas as well. And we often frame it as a workforce crisis and believe that truly. So really need to look at ways that we can strengthen and improve the LTSS workforce. Caregiving has been a theme as well, and it is a critical theme within the LTSS space. So that is another priority area of our recommendations. And then 2 more. The 5th one is payment models. So how does this get paid for? And how do we address those gaps? So again, a reason that I'm excited to learn about some of the new ideas shared this morning. And then also system coordination. So none of these systems operate by themselves. People with dementia and their caregivers interact with all of them. And while they may spend the most time interacting with the LTSS system, it is really important that these systems are well coordinated for the benefit of people with Alzheimer's disease and dementia and their caregivers. So go ahead and turn to the next slide then. So the first area recommendation, as I mentioned, is related to access. And what these recommendations really focus on are twofold, I would frame them. The first is really looking at disparities in access by various populations. So looking at marginalized, underserved groups, also looking at those who are living alone and isolated in our communities. And then also those experiencing homelessness. So that was a new addition this year, is to really reflect on the growing number of people who are experiencing homelessness and what can we do about that. And then also looking at access from the point of view of insufficient services. So when we don't have adequate dementia-friendly or dementia-capable support services, the impact that that has on access. So that is what the first set of recommendations focus on, or this first recommendation focuses on. A couple other details. So when we look at this first item about expanding the availability of culturally and linguistically tailored LTSS, the set of recommendations focuses primarily on community health workers and that particular model, bringing that model into the aging network and into community-based spaces. And then also looking at ways that various community health workers can coordinate across different systems of care. So where there are community health clinics or managed care plans, then the public health system where we have community health workers. If we grow this also within the aging network, that we're doing a good job of holistically supporting each person with culturally and linguistically tailored services. In addition to that, we specifically call out the request of Congress to allocate funding to pilot community-based dementia care specialists or navigator programs, also a word that was referred to earlier today and really links to the recommendations of our group. And then last, I'll also elevate aging and disability resource centers that have been significantly underfunded within our LTSS space, with the exception of Wisconsin, who has a really robust program and therefore can really see the benefits to having robust ADRCs as a place not only to access and navigate the systems that people interface with, but also to help address those unmet community needs and be the catalyst within communities to truly build out provider networks within our communities across the country. Then also when we're talking about dementia capable home and community-based services that are available, our recommendations focus specifically on adult day and adult day health centers, on expanded respite care options as a critical service. Then when we're looking at implementing strategies to reach people living alone and also those that may be social isolated, and looking at how loneliness impacts health outcomes. Here too, just again, reiterating the importance of things like dementia-friendly communities and continuing to expand those across the country, utilizing all sorts of resources that are already available, thanks to our federal partners, but really finding ways to continue to grow those throughout communities across the nation. And then, let's see, what else do I want to say about that? So I did mention the focus this time around on those experiencing homelessness. So just to call out that that was an addition in this year's recommendations. So because that is a growing challenge and clearly a system that is not dementia capable with, lacking data as well as, or underutilizing data that might exist, but people who are experiencing homelessness just not really having connecting points to community-based services or other ways to have access to shelters and that are dementia capable and other connecting points within the community. So I think that's all I'll say about recommendation 1. We can move on to recommendation 2, please. So recommendation 2 is related to the quality of care that is then received by people who do have access to them. So this is really looking, as I mentioned before, at ensuring that those services are person-centered and strength-based and across care settings. So in community-based settings as well as institutional settings. So there's also a focus on use of medications as interventions and really trying to minimize that only for appropriate use in and across these settings. Research has shown for years that they are overutilized. We've made some great progress in the last decade or so, but there's always a need to continue to educate around interventions that are not psychotropic medications and other medications rather than other types of interventions that are less intrusive. Then also looking at evidence-based dementia and caregiving interventions, specifically within the LTSS system, and increasing the availability of those as well as the utilization of them in various settings across the system. And then we also this year took a deliberate focus to look at people with advanced dementia. And so within this particular recommendation, we really focused on increase in palliative care and the ways in which it's applied in LTS settings and the connecting points that happen with the healthcare system in this space. And then also the great opportunity that always exists for future planning and assistance with that planning so that if and when someone reaches advanced dementia or end of life, that their wishes are known. So that is recommendation 2. We can move on to recommendation 3 then. So recommendation 3 is about implementing solutions to address the workforce crisis. And these look very short and sweet, but there are details within the set of recommendations, but really needing to increase efforts and implement system solutions at the federal level to address the workforce crisis. I think every state is looking at this issue and kind of independently trying to make an impact in their individual state and even at local levels. And I think what we're really looking for here is for alignment to happen within the federal level too. And federal government has levers that those other entities don't have. And so looking for ways that the federal government can pull those levers to help address this issue. The second part, one of the biggest issues that we hear about regularly within the LTSS workforce is the that it isn't often there aren't advancement opportunities, or that it's viewed as just low-level work. And I think there's great opportunity for us to create career pathways within this space to keep people in this workforce and see it as a career rather than just, a part-time job or something that they would do for a short period of time, but really establish a career pathway to get people more integrated into this work, more engaged and interested. This C there is looking at providing incentives for people to enter the workforce. So again, how can we incentivize people to participate? So looking at wages, looking at benefits, looking at solutions and throughout many systems to really look at ways that we can encourage people to enter this workforce. And then increasing availability and training, and also that supervisory support that we know is needed for people to be successful in the workforce. So getting people in is one thing, keeping people is another, but making sure that they have what they need to do quality work is a third piece here that is essential for this workforce. Next recommendation focuses on caregivers. So this is about ensuring family and unpaid caregivers of people with dementia have the support that they need. So the National Caregiving Strategy that was put together just this year, I think the official document was released. I've lost track of time, maybe it was last year. Anywho, really looking at an opportunity to align both our recommendations with the National Caregiving Strategy in all the places that they align, because they very much align actually in every space. So how do we take advantage of the network of folks that are working on caregiving strategies and ensure that dementia caregivers are considered in all that's being implemented as it relates to caregivers? One note that I'd like to make is that I do come from the aging network and the disability network and also the public health space. And at least for the aging and disability network space that I've been a part of, caregiving has been a topic of conversation for all 25 years that I've been a part of this network. And it is really humbling and exciting to hear how elevated caregivers have become in all of our spaces and how critically important that is. So really just want to, again, give a call out for that. And I'm just really excited and humbled to see how that's finally happening. And so thank you. Other pieces here is to increase access to, so focusing on information that we make available to caregivers. There's a call out for that to help them in their caregiving role, help them maintain them in their caregiving role, address caregiver burden and those other items that relate to this. And then finally, increasing caregiver strategies to reduce the financial burden and provide protections for working caregivers. So we know that so many caregivers are still in our workforce. And so if we can have supportive systems within all agencies, frankly, where working caregivers exist, it'll just make such a huge impact on reducing, first keeping caregivers in those roles as long as possible, but also the impact on the financial burden that can be addressed in that way as well. And then recommendation 5 is about payment models and looking at payment models to make it more affordable and to also eliminate the gaps in coverage among current government programs that support people with dementia. So Matt Janicki asked earlier today, what's the difference between, I think it was you, Matt, that asked the question about, what's the difference between this new program and programs that already exist and so on and so forth. And certainly we'll all learn more about it. But it did appear to me that it starts to address some of these gaps in coverage. And our group spent quite a bit of time talking about how if only Medicare would pay for long-term services and supports. And that was in essence what I was hearing is part of the new model that was shared today. Nonetheless, what we have here within our set of recommendations are to really look also at different insurance programs that exist already, long-term care insurance, how to make that more affordable, but also address some of the issues within that system, but really to prevent that financial insecurity of older adults and people with dementia of all ages is a really important goal. Second is to look at strengthening the Older Americans Act and other aging network programs to meet the increased needs and integrate people living with dementia. So there's some strengthening within the Older Americans Act that was mentioned earlier from the previous subgroup, and our set of recommendations also goes further in acknowledging some of the spaces where we see gaps within the Older Americans Act. And then the third part here is to eliminate gaps and increase coverage of LTSS under Medicare and Medicaid, as I was mentioning and we heard about today. All right, and then our last recommendation, recommendation 6, is to look at strategies that support coordination, integration, and dementia capability. So the first call out or the first system that's really important to focus on in terms of coordinating better is really looking at our crisis and adult protective services systems and ensuring that they can become more dementia capable, able to prevent abuse and neglect, respond to crises when they happen, stabilize people in place without having to, remove them from their home, for example, if it can be prevented. And then the second one is to look at strategies to improve coordination of the LTSS system with the behavioral health system. So this too was an addition to this year's recommendations, really wanting to acknowledge that there are some people that do have some behavioral health issues in addition to dementia. And so how do those systems interact with each other and best support people with dementia that also have behavioral health issues? And then also, and finally, the last piece of our recommendations focuses on enhancing alignment and integration of the healthcare and HCBS systems. And again, just that the visualization of that was quite evident when you looked at the clinical care recommendations and some of the other recommendations from the other groups. So this really, is the example of what we would like to see in terms of alignment and integration with the healthcare system and the LTSS system. So I think that's it for our set of slides, if I'm not mistaken. And I can open it up to any questions if there are any.
Thank you, Carrie, and to all the members of the subcommittee. Questions, comments for Carrie? Oh, Matt, do you have yours up? Oh, no. Now you have to come up with a question. No questions or comments. So I do again want to thank all the subcommittee chairs, subcommittee members for all their hard work behind the scenes to pull these together and present these recommendations today. We will take a 15-minute break and then we'll come back for voting, some final comments and public comments. Since it is some of our last NAPA meeting, because we'll be rotating off, we would like to do a group photo with all the federal and non-federal members and those online. If you could stay on for a quick picture before we take our break. You want to take off or put on your cameras, we can do a quick picture, but we'll reconvene at, let's see, 3:15 Eastern time. So, but if you could stay for a quick picture and then we will take a break and reconvene at 3:15.
Produced by the U.S. Department of Health and Human Services.